Hey everyone, and welcome to The Explainer. Today, we're digging into a piece of medical research that is, honestly, a true revolution. We're talking about a paradigm shift so profound that it totally upended decades of established surgical rules. We're going to unpack the groundbreaking findings of Dr. Angelita Habergama and her frankly pioneering watch-and-wait methodology for treating rectal cancer.
But right off the bat, I want to start with a pretty provocative question. What if the best surgery for cancer is no surgery at all? I know. It sounds totally counterintuitive, right? For a century, the golden rule of oncology has basically been, if there's a tumor, you cut it out, period. But what if doing absolutely nothing, at least surgically speaking, is actually the superior choice? That, right there, is the central medical mystery we're diving into today.
Now, to really grasp why asking this question is so vital, we first have to talk about the incredibly high stakes for the patient. The traditional treatment for distal rectal cancer involves radical surgery, specifically removing the rectum itself. And the physical toll of that, it's terrifying. We're talking about high surgical morbidity, mortality rates of up to 5%, and for the vast majority of patients, a permanent colostomy bag. On top of all that, up to 25% of these patients suffer severe, permanent sexual or urinary dysfunction. And that's even when the surgery is performed perfectly. So the human cost here is just staggering.
Okay, let's move into Section 1, the rectal cancer dilemma. So right up until Dr. Habergama began publishing her data, patients routinely received neoadjuvant chemoradiation. That means using chemo and radiation to shrink the tumor, which was then followed immediately by radical surgery. But here's the shocking statistic Dr. Habergama highlighted in her 2004 study. A whopping 72% of patients whose removed surgical tissue showed absolutely zero viable cancer cells, what doctors call a complete pathologic response, while they still underwent those life-altering stoma surgeries. I mean, really think about that for a second. They endured the massive trauma of losing their rectum and getting a permanent colostomy bag to remove a cancer that the chemo and radiation had literally already killed. And this agonizing contradiction is exactly what led to the crystallization of a term you absolutely need to know today. Complete clinical response, or CCR. This happens when a tumor completely disappears and is totally undetectable by clinical, endoscopic, and radiologic assessment following the chemoradiation. Basically, no mass, no ulcer, just normal tissue or maybe a flat scar. Understanding this definition is totally crucial because it's the absolute linchpin of Dr. Habergama's entire methodology.
Which brings us to Section 2, a radical medical idea.
Okay, let's dive into this, because the hypothesis for this new idea was incredibly simple but totally earth-shattering. The old way was essentially a rigid assembly line. Chemoradiation, straight to radical surgery, straight to a stoma. No stopping. But the new idea, it interrupts that assembly line. You do the chemoradiation, sure, but then you pause. You check for that complete clinical response. And if the cancer seems gone, you just watch and wait. It was a completely revolutionary, non-operative leap of faith. And let me tell you, the medical establishment was not exactly thrilled at first. The skepticism was intense. When Dr. Habergama presented these findings back in 2004, her esteemed peers were incredibly cautious. Dr. Fabrizio Michelasi noted, "The results presented today challenge the current surgical principles, potentially change current practice." He pointed out the massive anxiety of potentially leaving microscopic disease behind. To a lot of surgeons back then, the idea of leaving a patient unoperated when standard practice literally dictated resection sounded absolutely crazy. It was highly controversial.
Let's look at the data in Section 3, the 2004 breakthrough results.
So to see if this wild idea could actually work in the real world, we just have to look at the 5-year survival rates from that landmark 2004 study. Get this, the observation group, the patients who just watched and waited, had a 100% overall survival rate. Compare that to 88% in the resection group. The observation group didn't just survive, they actually out-survived the surgical group. And there was zero cancer-related deaths in the observation cohort. Zero. They kept their rectums, they maintained their quality of life, and they lived.
All right, moving on to Section 4, perfecting watch and wait.
Now, while that 2004 data was super promising, the researchers obviously wanted to get even more patients into that coveted complete response category. They realized they needed a brand new recipe to maximize tumor shrinkage. The original 2004 recipe used 50.4 GY of radiation along with standard chemo. But under the revamped 2013 recipe, they bumped the radiation up slightly to 54 GY. But here's the real key, the extended chemotherapy. They delivered 6 cycles of chemo, notably continuing it right through the resting period after radiation was completed. This essentially gave the tumor way more time and way more toxicity to just fully die off before they even assessed the patient for surgery.
And the results of tweaking that recipe? Absolutely phenomenal. With the new 2013 protocol, an initial complete clinical response was observed in a massive 68% of patients. We're talking nearly 7 out of 10 patients seeing their tumors completely vanish on clinical assessment, just from this extended chemoradiation block.
But as you might guess, initial disappearance isn't really enough to declare total victory, and that brings us to another super vital concept: sustained, complete clinical response. Basically, this means maintaining that complete response for at least 12 months after chemoradiation with absolutely no local failure or regrowth whatsoever. The researchers actually noted that the first 12 months are the most critical window. If the tumor is going to aggressively grow back, it almost always happens in that first year.
And this brilliantly illustrates exactly why that first year matters so much. When you trace the 3-year survival data, the overall survival remains incredibly high. We're talking around 90% at the 3-year mark. Now, the disease-free survival does drop slightly in that first year, which reflects those early regrowths we literally just talked about, but then it completely levels off. This strongly proves that the method is durably safe for the vast majority of people.
This brings us to our final part, Section 5, a new standard of care.
So with the long-term safety finally proven, this protocol was formally implemented into a highly practical framework. Now, what's really interesting about this exact decision tree is that it proves this isn't just a go home and hope for the best situation. Not at all. If the assessment is normal, you stay in the loop. If there is a gross tumor, you go straight to radical surgery. But taking the middle path, say there is just a subtle irregularity, well, they perform diagnostic local excisions or frequent MRIs. It maps out exactly how safe, incredibly methodical, and honestly hyper-vigilant this entire process is. But look, we do have to ground ourselves in reality here for a second. There is a catch to all of this. The heavy cost of the watch and wait method is a lifetime of intense, relentless screening. The patient absolutely must be fiercely compliant. We're talking monthly visits in the first year alone. You've got frequent, expensive MRIs and PET-CT scans. You have uncomfortable, rigid proctoscopies. And if anything looks even slightly suspicious, you're going in for a diagnostic local excision. It requires a massive, massive psychological and temporal commitment from the patient. But the emotional and physical payoff for that massive commitment, it's undeniable. Because of this refined 2013 method, over 50% of the total patients in the study never required life-altering radical surgery. Think about that. Half of the patients walked away keeping their normal anatomy, completely avoiding a permanent stoma, and dodging surgical morbidity entirely. They beat rectal cancer without a scalpel ever removing their rectum.
So, as we wrap up today's explainer, I want to leave you with a pretty powerful question. If watch and wait can safely cure rectal cancer, which is historically one of the most brutal cancers to operate on, how might this philosophy change the future of all cancer treatments? I mean, could we eventually see a world where targeted therapies melt tumors away across the board and the surgeon's knife becomes just a tool of the past? It's a pretty thrilling thought, isn't it? Thank you so much for joining me to explore this incredible medical innovation. Keep questioning, keep learning, and I'll see you in the next explainer.